Welcome everyone to today's program. I'm Heather Punke, editor of Becker's Infection Control and Clinical Quality. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at this time, but that email will not include the presentation. It is now my pleasure to introduce today's presenter. Jim Goche serves as the Senior Clinical Advisor of Infection Prevention to North American Healthcare Team of Sealed Air Diversity Care. In this role, Jim serves as an infection prevention and control resource and an industry liaison with organizations to assist with the expansion and improvement of environmental hygiene solutions and science-based best practices. Jim has more than 35 years of experience in medical laboratory technology and infection prevention. His focus has been across many healthcare areas, including acute, ambulatory, behavioral health, and long-term care. It is now my pleasure to turn the floor over to Jim to begin today's webinar.
Thank you very much, Heather. I appreciate the time you've taken with that introduction. So welcome, everyone. You can see my slide here. I'm going to be talking about effective cleaning and disinfection. Are you addressing the risk? And the risk I'm talking about here is of trying to reduce healthcare-associated infection, or HAIs. So my objective here is three things. I need to take a look at what the problem is, which are healthcare-associated infections that we all face in our day-to-day activities as being healthcare professionals, and trying to address the risk of reducing these infections. Then I hope to offer some solutions and a summary of what we can do to keep this as minimal as possible. So what is the problem? I think we're all well aware of this. I recognize that not everyone listening in is from the United States, but I'll try to address this from a global perspective. Definitely in the United States, we know that there's a huge issue with our healthcare-associated infections, with the estimates of 1.7 million infections occurring in the U.S. healthcare facilities on an annual basis. And you can see the numbers on this slide. It's leading to costs of anywhere from $28 to $45 billion a year that could be spent much better on other technologies and modalities other than trying to help stop or treat these healthcare-associated infections as they come up. In Canada, the numbers are similar, smaller because we're a smaller population. I keep saying we, I'm actually a Canadian, and so I'll keep referring to myself in the editorial we around Canadian healthcare system. But we have healthcare-associated infections also affecting 1 in 9 of our patients. Our costs are estimated to be in the billion-dollar range annually. We've got lots of studies that look at the impact that this has, and I've got some references here from the study that was done in 2011 looking at this with UMSHEED, and we've got numbers that will show us on average patients are going to spend an extra 8.9 days in the healthcare setting if they have a healthcare-associated infection. And the paper looked at all the different problems that they've seen, and in 2011 was estimating that up to 70% of healthcare-associated infections can actually be prevented. So it's very important for many healthcare settings. In the United States, they're well aware of the impact that the Centers for Medicaid and Medicare has. And for the Canadians and other folk that might be listening into this from other parts of the globe, this graph and table here is basically showing us, the analogy I like to use is the Americans are facing a giant game of blackjack. Every hospital and healthcare setting antes up into this program. Those that are in the high performance settings, being measured on the different impact factors that are here, those that are doing well get money back and money added into what they actually put up as an ante. Those that are in the mid-range is a push. They've tied the dealer, they're going to get their money back. Those that are at the bottom, performers, lose their ante. So everyone puts money up, and to healthcare settings then, this is very, very important because there's a lot of money at risk here. These are all published. You can go to the website and look up to see which hospitals are the best performing. If you're having a procedure, you can go to that hospital site and see how they rate in some of these areas. So there's a lot of openness to what is going on within the healthcare settings. So I'd like to put out there, can you imagine the response you would get if you walked into your C-suite and said, I can come up with ways of reducing healthcare-associated infections by a minimum of 20%. And I'll be talking about a study that managed to do just this. But I have to admit, there is no one easy answer. This is definitely multifactorial. There's not just one single silver bullet that's actually going to make a difference to what we're seeing in our healthcare settings. We know that reducing the risk is much more than just using a disinfectant. And, yes, I do work for Sealed Air Diversity Care, but there's much more to this. It's a definite part of it, but we know it definitely takes an integrated approach. We need very effective products, we need well-defined procedures, and we need a good validation program that will assure that what we're doing around the cleaning and disinfection is going to reduce the healthcare-associated infections. But beyond just using a disinfectant, we have to keep in mind that we also want to make sure that we have very good protocols around our central lines, our eclampsies, around our catheter-associated infections, getting urinary catheters out as quick as possible. For surgical site infections, we want to make sure that we've got our antibiotics on board the way they're supposed to, and have definite defined procedures for them to try to reduce our healthcare-associated infections in other areas. Plus, we want to make sure we have a good antibiotic stewardship program in place so that we are not precipitating Clostridium difficile infections. We need to make sure that our hand hygiene programs are well recognized and well audited in not only our staff, but we also want to make sure that these programs are in place for our patients also, because many of our patients, when they're with us in our healthcare settings, cannot get to a readily available sink to sanitize their hands or wash their hands, and they may not have within their reach the hand sanitizer that they actually need to make sure that they're not going to inoculate themselves or use their mouth as the portal of entry of some of these organisms. So there's three things here that I'm going to focus on as we try to address the risk. So we want to take a look at the products that are in use and issues with our products. We want to make sure that we look at the procedures, and I've got some suggestions around this, and then the validation component of it. As I've alluded to here, the healthcare-associated infections have many components that lead to an HAI. I'm not going to focus on the device-related, the device-associated or the procedure-associated things. I do want to just focus on the outbreaks and organisms that we see much more on our day-to-day problems that we face. So this graphic here, a lot of this information, I've got the reference on the next slide as to where this actually came from, but we're well aware that the environment does play a role in the transmission of problems. We have pathogens that are going to be in our environment. We know they're going to be found on the high-touch surfaces around our patients. Many of these pathogens can survive up to months. There was a good study that did a summary of all of that, and we've got pathogens that for easily 3 to 4 months, 4 to 5 months, will survive in the environment, and these aren't spore-bearing organisms. These are just some of our vegetative bacteria like Klebsiella. They're just hardy environmental bugs. So once we have them in the environment, it's very easy for them to move directly to a susceptible patient. They can contaminate the hands of our healthcare providers, who then take them into the patient's environment. The green diagonal arrows here are both areas that we can actually stop this transmission, or again, if we use the chain of transmission analogy, we're going to break the chain through good environmental hygiene, getting rid of our reservoir that we might have, and good hand hygiene is another way to break that chain of transmission, the mode of transmission back and forth to the patient. The study that had a very similar diagram to that, but went into a lot more detail looking at the risks from the environment, with Dr. Otter et al. The title of this paper was "The Role Played by Contaminated Surfaces in the Transmission of Nosocomial Pathogens," and reviewed a bunch of literature looking at this. And this information was pulled together within that paper, indicating that if you go into a patient's room where the patient ahead of you has had some form of MRSA, VRE, C. difficile, multi-resistant Pseudomonas, you stand anywhere between a 1.3 to a 3.5 increased risk of acquiring that organism. Which is huge, significant, and it indicates some of the issues that we have around our environmental hygiene practices that we have in place. There's another paper here by Kundrapu that looks at how important it is to do daily disinfection of surfaces. So their baseline that they looked at was just cleaning high-touch surfaces when they were visibly soiled. And then what they implemented is actual daily disinfection of the high-touch surfaces. And their definition of the paper of high-touch surfaces were things such as the bed rails, bedside tables, call button, telephones, definitely doorknobs and handles, bathroom handrails, things like that, the toilet seat. And so what they put into place, and you can see on the graph here, is just using standard cleaning, where they just did some high-touch surfaces if they were visibly soiled. They actually put in a procedure where an actual disinfectant process was done on the high-touch surfaces. They checked these surfaces by touching them with a sterile glove and seeing what they could transfer to an agar plate. And you can see on here that as soon as you get into a regular cleaning and disinfection of high-touch surfaces, the amount of organisms or the number of positive hand cultures drops right off. This is a sample of one of the graphs from that paper, but for both C. difficile and MRSA or MRSA, the ones that they were looking at showed this reduction. So the hand cultures went from being positive in 70 to 80% of the cases, dropping down to 0 to 20% after they got this cleaning in place, which is definitely quite significant. Another study that looked at what happens when we get much better about cleaning and disinfecting the environment is this study here by Alpha et al., where the title is "The Use of a Daily Disinfectant Cleaner Instead of a Daily Cleaner Reduced Hospital Infection Rates," and that was published in 2015. And this was a paper where she took accelerated hydrogen peroxide pre-wetted wipes. So the bucket comes, there's 160 wipes in here, and they just totally switched to using these wipes in all patient rooms, both regular patient rooms and patient rooms that were on isolation. That was during the study for a year. That was the only thing they changed within their healthcare setting. There was no special education going on around hand hygiene or other aspects of things that we all try to put into place. And what this paper showed is that it reduced all rates by 20%. So this, what they were monitoring was MRSA, VRE, and C. difficile. So using a daily cleaner disinfectant reduced even their C. difficile rates by 20%. And they attributed this to a couple of things. One is they also made sure that the amount of cleaning and the accuracy of their cleaning, which they were auditing, was in the high 80% range. So they were using the fluorescent marker with an ultraviolet light going around to make sure that the surfaces were being cleaned. And once they got their compliance up to that 80% range, using a good cleaner and disinfectant with disposable cloths, and there was no mixing problems or any errors like this that could come into this, they showed this 20% reduction. So in the paper, they estimated a cost avoidance of over $600,000 a year due to the healthcare-associated infection rate reductions. And the summary of the paper was, you have to have three components: the use of an effective disinfectant cleaner, a clearly defined protocol with education to the staff, and they made sure that there was instantaneous feedback. So after the rooms were cleaned, somebody went into audit with where the marker had been, and it was instantaneous feedback to the environmental service person. And the third point of this was compliance monitoring, the staff feedback. So the protocol was very well laid out, where what they actually had in place was, it was very clear that you use 2 wipes for your daily clean for the bed, bedside table, chair, and they actually wiped the leading edge of the hospital curtain. They used another wipe, a single wipe, for the common area between the 2 bedded rooms that they had at this hospital, and doing things like the doorknobs and the computer keys and things like that. And then they had a very clear picture of 3 wipes would be used in the bathroom and how that was done. And in another presentation that Dr. Alpha did, I've seen the schematic that she actually had of how this was laid out on a piece of laminated paper for the employees to use, to know exactly what their procedure was to use these wipes effectively. On discharge, they definitely use more wipes because then, you know, both sides of the mattress needs to be done, the bed frame would have to be done. And in the paper, they discuss on how this was modified for a discharge clean, but it was very, very prescriptive as to what they had to do to make sure that they achieved this kind of clean. So we like presenting this in our 3 little circles here, that if you have a good product that's an effective disinfectant cleaner with very well-defined protocols and the education, good validation, you can show a 20% reduction in your overall healthcare infection rates. So let's look at some of the products and the issues that we can actually run into with these. There's a very good paper done by Dr. Bratella and et al. On what you would want in an ideal disinfection. And there's sort of numerous considerations, and they lump into about 5 groups. You want to make sure that you can kill the most prevalent healthcare-associated pathogens. You want fast kill times with acceptable wet contact times. You want it to be safe. You want it very easy to use, and some other factors that he tied in on the paper here. And I'll look at some of these in a little bit more detail. So the products in the paper, they actually listed these organisms here as to sort of the common healthcare-associated pathogens that we see causing issues. I do recognize now that Clostridium difficile is probably the primary pathogen that most of us are battling within our healthcare facilities. But other things that show up commonly, and in his paper, he attributed probably a quarter of our healthcare-associated infections not related to C. difficile are caused by Staph aureus and E. coli. The top 5 listed here made up over half of the healthcare-associated infections in the research that Dr. Bratella had done. So you want to make sure that your product is definitely going to handle your gram-negative organisms, your gram-positive organisms. It has some fungicidal activity around Candida albicans and things like that. The other thing with your disinfectant is you want to make sure that it doesn't dry too fast, and this is the contact time. You have to have a contact time that's reasonable. I know from looking at the IP talk at the APIC website that a lot of people are now being recognized to the Joint Commission that they come in time. If you have a disinfectant that has a 10-minute label claim, they stand there with a stopwatch to see if it's kept wet for that 10 minutes. So you want to make sure that your wet time from your wipes, be it a bucket and a cloth method or a pre-wetted wipe, you want to make sure that the wet contact time is going to give you the time that you require. So if it says 1 minute, that is going to stay wet for 1 minute. If it's a 3-minute label claim, you want to make sure that that surface is going to stay wet for that 3 minutes. So you have to be very aware of your evaporation issues. If the chemistry that you're using has solvents in it, it could evaporate off much quicker than what the label claim is for the actual product to use. If you're in a part of the country that's very, very dry, your disinfectant on a surface is just going to add to the local humidity and evaporate off very quickly. So there's a couple of things that everyone should really be taking a good look at with their product. Another issue that we face with our products is this quat binding. And I'm still finding as I go around the country talking to different groups of infection preventionists that there's still some eyebrows going up around the quat binding issue. So this is becoming much well recognized. It's not as widely shared as it probably should be, but there's this issue with a quaternary ammonium-based product having a charge that is opposite the charge of the cloth. So the actual active ingredient is bound onto the cloth. Sometimes it's microfiber, definitely with cotton cloths. And what happens is when you wipe that chemistry on a surface, the quat doesn't actually get released back. And there's been several studies that have looked at this issue of the quat doesn't come off when you wipe. So those of you that are using a quat-based chemistry need to make sure that the cleaning cloth that you're actually using isn't absorbing anything. Because you're going to find you're probably having issues with some of your organisms that should be easily killed because you're not putting down the concentration in terms of parts per million on the surface that you thought you were. One of the papers I do want to share is very recent. It was just published earlier this year in Infection Control and Hospital Epidemiology, and Dr. Boyce and his researchers tested the quat binding capabilities of microfiber cloths, cotton towels, and some disposable wipes that they had. So the graph here shows a rapid fall off for both the cotton cloth and disposable wipe A, that within the first 5 minutes, over half of the chemistry, because they wanted it to be at 800 parts per million, in 5 minutes, over half of the chemistry had been absorbed onto these cloths. And the disposable cloth went on to, basically within 30 minutes, it absorbed all of the quat. A little bit of research that they did into this disposable wipe, they found out the wipe was actually being used throughout their healthcare facility, but was actually labeled for use with solvents, that it wasn't actually supposed to be wetted with a disinfectant for healthcare surfaces. So they changed their disposable cloth and found that it had a lot less quat binding. They actually didn't see any quat binding until about 30 minutes to an hour into the actual soaking time. The microfiber cloth that they were using is sort of the middle bar here that drops off to they lost from 800 parts per million down to just about 600 parts per million in the first 10 minutes. And he describes the fibers that are actually in the microfiber cloth that they used. Before I saw this paper, I always thought that microfiber cloths would not bind it because they're much more synthetic and made that way. But it brought to my attention definitely that if almost regardless of what cloth you're using, if you're using a quat-based chemistry, you really should be checking that combination. And there are dipsticks that you can get to show you the concentration of the quat. Most manufacturers will provide or make sticks available that you can check to make sure that if you're diluting a concentrate to a ready-to-use format, that you've got the right concentration going on. The other reason checking it is important is the next slide I have here. He also checked and found that of the 33 dispensing stations that they had, none of them were issuing a finished product at the 800 parts per million that the manufacturer was recommending. So you can see here there were 7 that was way over diluting it. They were only getting 200 parts per million. 2 of the dispensers actually had no concentrate in it, and one of them was inoperative. So none of them were actually dispensing the 800 parts per million. Most of the problem with the ones that were actually working was around water pressure. And they had to actually put some pressure valves into their system, into each of the closets, to ensure that the actual concentration was coming out the way it was supposed to. So from this, I would recommend to all of us that if you're using a quat-based chemistry, you check to make sure that you've got a good compatibility between your cloth and the chemistry that you're using. And if you're using a diluting system, that you have a way of checking to make sure that your diluting system is working. As to how frequently, that's sort of a standard operating procedure that you can come up with internally within your facility. Personally, I would recommend that every time a bottle is changed within the system that dilutes your product, that you check it to make sure that all of the connections are hooked up the way they're supposed to be. Everything's tight. What's coming out into your bucket is the proper dilution. Then there was another study that not only looked at it had recognized within the study that there was an issue with quat binding, but Cifuentes and the group there looked at clean cloths that had come back from laundry. What could they find on them? And it was a scary study to read because they found that 93% of the reusable cleaning cloths that came back had some form of bacteria on it. Many of them recognized as being pathogenic if given the right portal of entry and susceptible host. So their summary of this was that typical laundering practices were not sufficient to actually remove the microbial contaminants, and that these clean cloths that were taking up into patient areas, yes, if they're going back into a disinfectant, that disinfectant should be taking care of the organisms there. But if I use one of these contaminated cloths to wipe up, say, a water spill or a coffee spill in front of a patient, I'm actually then putting more bacteria on the surface. Some of the organisms that they were finding were things such as environmentally named organisms, or organisms I recognize as coming from the environment, things like Pseudomonas, Serratia, which is a great bug for living out there in the environment. They found Klebsiella, Pasteurella, Aeromonas, Micrococcus. Some of the cloths had fungi on them, such as Aspergillus niger, Fusarium, and Clavosporium. Over 56% of the cloths had aerobic spore-bearing organisms, such as Bacillus cereus, present on them. They did not find Clostridium difficile on any of the wipes, and they did not find any MRSA on any of the wipes. It was more other environmental organisms that they were picking up on it. But over 23% of the cloths had coliforms present on it. These gram-negative rods and stuff like that. The other thing they found is that microfiber cloths had more organisms, significantly more organisms than the cotton-based cloths. So not only do microfiber pick things up much better, they just don't like letting go. And a lot of this depended on how the cloths were being laundered. So it's another thing that we have to add to our list of things if we're using reusable cloths that we have to worry about with our procedures and stuff that we want to check to make sure we're trying to reduce this risk as much as possible. So with our products, we also have to be concerned about our safety concerns with the chemistries here. The reference on this slide, I'm not sure how you're projecting it, but the first reference is from an Occupational Environmental Medicine journal. The second reference is actually from MMWR, Morbidity Mortality Weekly Report, from 2010 that was looking at staff that had been exposed to pesticides, as they called it in general, because these things all classify as that. But it looked at different studies from, I think it was 4 different states, California, Louisiana, Michigan, and Texas, and the issues that they ran into. Some of the summary costs on this were huge. They found the active ingredients that were causing the most issues were things such as quats, glutaraldehydes, and sodium hypochlorite. Damage to eyes, neurological issues, respiratory issues. They extrapolated the cost through these two papers up into the $45 million range over a 5-year period to address the occupational health and safety concerns. Now, this is from 2010. I'm not sure, I haven't seen anything more recent in terms of some of the newer chemistries that are out there and issues around staff occupational health and safety reports that come from it. And this was all part of Dr. Bertella's original paper. You want to make sure that the solutions that you're using are safe, that the staff are likely to use them. We know that if staff are fearful of the disinfectant that they're using, or if, and I've heard this reference, it was actually from someone sitting next to me on an airplane who worked in healthcare, and she referred to the cancer wipes that they're using. And I thought, really? I run into somebody that refers to their disinfectant pop-up wipes as a cancer wipe because staff were afraid to use them. So you want to make sure that your product, again, is safe. You want to have it in a patient care area. I think we need to really focus so much more on having point-of-care disinfection on top of our point-of-care hand sanitizing. We want to have a product that's available so that if a healthcare provider is performing a procedure with the patient and they know they've soiled the environment, they've touched a side rail inappropriately, or they put a soiled brief on top of an overbed table because there was nothing else handy to do with it, that there's a readily available disinfectant wipe that's safe to have there, safe to use in front of the patient, to clean that area. Our EVS staff come through once a day, do a phenomenal job if we're auditing them to make sure that all the surfaces are contacted the way we're thinking. But for the next 23 hours and a bit, we want to make sure that there's something available. We also want to make sure that it's safe for the hospital surfaces. That was the other aspect. It's not on this slide here, but it was in the original paper, that you want to make sure it's not going to be breaking down the surfaces that you're using it on. Ease of use is very important. You want it convenient. Again, the accessible comes up here. If people have to go wandering off to dilute a product into their own container to take it back to a patient's room to clean a surface because the EVS supply is not readily available to them, they're not going to do it. I'm always been in favor of these pre-wetted disinfectant wipes that are readily available. If they're safe enough, it's great to have them within patient areas and patient spaces. A lot of this you can determine from your product if it's safe enough to do that with is based on the HIMSS rating. There are products that do not require you to have gloves on to actually touch the product. If you're cleaning up blood or body fluid spills, yes, with your standard practices, you need to make sure that you've got your personal protective equipment on appropriate to what you're cleaning up. But myself, as an educated family member, my brother was admitted to hospital. He got moved out of an intensive care unit into a regular patient room, 2-bedded room, where he happened to be. I went off and found the disposable wipe, brought it back to the room, and I had to go hunting for it. It wasn't readily available. And the surface I always like to wipe is the underside of his overbed table, where he would pull it towards himself to reach his food tray. And I actually found visible soil that came off on this cloth. So as an educated family member, if there was a product within the patient room that was safe to use without gloves, that's the ideal situation for me, where I could wipe off the overbed table or the side rails as a visitor or as a family member, depending on how the situation is. So the ease of use, the readily available, having it accessible is very important when you consider your product. So let's move on and look at the procedures that we have with our actual cleaning and disinfection. So the important thing with procedures is we need to make sure that everything ties together. Everyone has to understand what they're supposed to do in terms of cleaning before disinfecting. If you're using an integrated product that is a cleaner disinfectant, you still have to clean the surface if it's visibly soiled. Use a second wipe to then top up that surface. With a good cleaner disinfectant, you don't need to do the double wipe if it's not visibly soiled. Best way to check that is take a look at the cloth. That's generally what I end up doing if I'm actually using a cloth to see how dirty a surface was. You want to make sure that everything is laid out in very clear steps, that you've got an operational efficiency around the actual procedure of what has to be done. A lot of this can be tied into a functional bundle, much like what we're doing with line insertion and stuff like that, a step-by-step-by-step checklist of what has to be done. So back to this article, that we know that daily cleaning is critical in using a good disinfectant on surfaces. All high-touch surfaces is going to knock down how much you're actually exposed to in terms of positive hand cultures or the actual culturing that they did in the environment with this study. The roles and responsibilities are also very important, and having a clear list. I was just commenting on this on the IP talk, actually, that you need to have very clear, or sorry, it was with the AAG organization, where environmental services are being given more patient equipment to clean. And I said, that's fine and dandy, but you need to have a form where you can actually say, this is all the equipment that we have in this unit. This is what's cleaned by EVS. This is what's cleaned by your nursing staff or other people, depending on how it's going to work. You need to know the frequency when it's going to be cleaned. Is it daily? Is it after every use? Weekly? Depends on what it's being used for and the risk of contamination. What is used on it, which is very important. With some manufacturers' instructions, they have their very clear recommendation on what needs to be used. And if the product that you're actually using isn't listed by that manufacturer, contact your distributor of that product. All of the companies are constantly looking at how our products react with different surfaces and stuff like that. And we may be able to provide you instantly with testing that we know has been done either by the manufacturer or ourselves for the manufacturer, so you know that the product is safe on the piece of equipment. The how to clean is very, very important. If you've got people with questions as to what's going on or who cleans what, it's not going to happen. I was thrilled to find an environmental services manager happened to be having breakfast next to me at a conference I was at, and she casually mentioned that she gets 45 minutes at orientation with all staff to talk about who is EVS, what do we do, and oh, by the way, this is how you use our disinfectant wipes and how you clean different pieces of equipment that staff are expected to clean after use. And she had 45 minutes, and it just blew me away that there was one facility that puts this much time and effort into making sure all staff knows their roles, their responsibilities, and definitely how to do the cleaning that needs to be done on these surfaces. So this picture here is just a larger example of listing down of all the products that are on the one side and making sure that everyone knows exactly who is supposed to use it. So the use of disposable disinfectant wipes, I always like this concept because it eliminates the problem of these things going off to be washed and coming back potentially with bacteria still on them or more being added to them after they've been left or after they've been cleaned, because that paper by Cifuentes actually was, they didn't know where the bacteria came from, whether it was through the actual cleaning process or whether it was all the handling that has to happen to get it back up to the healthcare unit where they actually took these wipes from. The study by Weinken in 2014 took a look at the value of a ready-to-use disinfectant wipe versus the reusable wipes, and in essence felt that it was a cost saving over traditional towel and bucket method in the long run, because you save so much time in many areas. You save time in terms of having to check product and stuff like that, because if your bucket has the expiry date within place, the manufacturer will let you know what the expiry date is once it's opened. You should not have any waste going on. If you've got waste going on, the manufacturer usually will have several different sizes or volumes of wipes that you can actually utilize to make sure that things are rotated on a very regular basis. But the summary of this article was, if anything, it's a cost savings to actually go to disposable. In terms of the carbon footprint, there's the two things that you have to look at: how much carbon you're generating by loading the stuff onto a truck to drive to the laundry, to use hot water and chemicals to drive it back to your laundry, as opposed to putting it in with the regular waste stream that goes off to landfill. There's definitely an impact from both systems, but it's something that would have to be looked at if you're considering moving to this system. I find this graphic shows well that the bucket on the right-hand side is 160 pre-wetted wipes compared to 160 microfiber cloths. We don't have the issue with shrinkage, which is the very polite term for these things walking out of the building and not coming back. But it's a very cohesive, neat setup where it's readily available on your environmental services cart. They're easy to use, they're easy to get rid of. There's no issue with things coming back, being torn, keeping track of the number of times they've been washed, how they're washed, do they have bacteria on them. It's just a much more efficient system for each healthcare facility. Having training tools is another part of this procedural step that we really need to take a good look at. We know that if we tell people exactly what they're supposed to do, it makes it easier when we audit it. so that we can say, we've showed you you need to clean this surface, this surface in this order. If you have staff that English is not their first language, you can get training tools such as pictured here that can be translated into different languages. The product on the right there, the patient room daily cleaning, is actually a schematic of what everything looks like that you would wipe down as you work your way through the room, with it all being color-coded to indicate when you would change your cloth. This way is much easier to train people and then to audit afterwards. Because many times I think a lot of our pushback around doing the environmental auditing is, I've never been shown how to do that, or I didn't realize I had to do all of that. And if you've got the training and activities in place like that, it just makes it so much easier to take the next step, which is into the validation process. So let's segue into the validation process. So validation is basically boiling down to, are you confident that the job has been done and all areas have been wiped the way that we think they're going to be, and that all of your procedures have been done? Validation is a critical third part of this. On top of having the product that is going to do all the stuff that I've talked about here and procedures in place to make sure that people are doing it effectively, you want to validate that all of those have tied in together. And it's important enough that the Centers for Disease Control had published this document on options for evaluating environmental cleaning back in December of 2010. It recommends everyone has a procedure in place to make sure that all your high-touch surfaces are cleaned as part of terminal room cleaning. Now, I recognize most of my audience is American. The province I come from in Canada, we have our Provincial Infectious Disease Advisory Committee that has very similar recommendations on how we clean and sanitize and disinfect our healthcare environments. The documents put out by PIDAC do much the same thing and also focus on the validation and auditing of what's happening. It's also important enough that both SHEA and the IDSA, when they were talking about Clostridium difficile, had language in there that indicated you have to routinely assess what is happening to make sure that you've got adequate cleaning and disinfection happening. And they also said when you've got issues with your background organisms, if you've got an issue with Clostridium difficile or other pathogens, especially things like the CRE, our carbapenem-resistant Enterobacteriaceae, ESBL-producing organisms, what I like to call the fecally spread stuff. If you've got an issue with that, before you go running off and switching your chemistry, check the adequacy of your cleaning and disinfection practices. Are your diluters working? Are your cloths binding the quat that you're using, if that's what it is? Are all surfaces being wiped down? Have you actually done more than just looking in the room and saying, yeah, that looks clean? Because this is a vitally important issue for making sure that everything is happening before you go off and actually switch your product. In this article from the SHEA and the ISDA, they're saying, you do need to consider using a sporicidal if your cleaning and disinfection practices are adequate, but you're still seeing ongoing transmission. And if you're in a hyper-endemic setting, then yes, there's other things that you need to look at, but it's not the sole solving of all of your issues. Sealed Air Diversity Care likes to refer to our sporicidal agent as very task-specific. You will use it in certain circumstances within the room of a patient that has C. difficile. And a lot of this stems back to the study by Alpha that I've already presented, where if you have good cleaning and disinfection with a good product, so you're removing the spores from the surfaces, you can reduce your C. difficile by 20% with a product that didn't have a sporicidal label claim. There are times you do need to step it up, but instead of going top to bottom throughout your entire facility with a sporicidal agent, start checking what's going on with the current product that you're actually using. That's probably much more important. So the CDC paper went into looking at your evaluation program. And the level 1 part of it was, let's take a look at what the responsibilities are, how frequently are things done. Does this surface get done on a daily basis, a weekly basis, after every use? Having very structured, documented education of your EVS staff, and as I mentioned earlier, anyone else who you're expecting to clean. Just because someone carries an RN after their name or an MLT like myself as a lab technologist does not mean I know how to use a disinfectant wipe on a piece of equipment. There's lots of surfaces that staff probably don't want to touch, making assumptions around what it might do to that piece of equipment. So we have to be very, very certain that our staff are cleaning appropriately. I found this very interesting. I was asked to look at how cleaning occurs in dialysis suites. And when I talked to the facility I used to work at that had a 12-bedded dialysis suite, I was informed that the EVS staff cleans the chair that the patient uses, empties the garbage that has accumulated during the dialysis program, the high-touch surfaces around that, and the dialysis nurse cleans the outside of the machine. So there was a clear delineation of who cleaned what. But what I didn't know is, had those dialysis nurses been shown how to use the product that was in use? Was it a ready-to-use wipe, or did they have to get something from the janitor closet? There's all those other questions that would have to be asked. So you want to make sure that you've got a monitoring system that measures staff competency and incorporate those staff satisfaction survey results. When we ask our patients, did your bathroom appear clean? You want to make sure that things are done in a way that your staff satisfaction surveys reflects what's actually happening within your healthcare facility. The Level 1 program has interventions, what you would put in if there's issues around the quality of cleaning and disinfection. And having that documentation in place and everything stable is what you would have before you move on to the Level 2. The Level 2 is making sure all of that is happening and then doing the covert assessment of what's happening using the generally regarded as acceptable methods, and there's some argument about that, I'm sure. So, we can use accepted methods in the CDC paper here was, direct observation of watching them do the surfaces, using the occult fluorescence and making sure that your product is not visible, using ATP, which has some inherent problems with it. And I think our procedures around ATP are getting a bit better, but again, it's not giving us, is it a viable bacteria or a dead bacteria that's showing up here? Culturing, that's very difficult too. That's very technique dependent as to what's going on. CDC doesn't recommend the post-cleaning inspections where you look around the room saying, yep, everything's clean and shiny, because that's definitely not one of the better ways in assessing what your actual procedure is looking like in there. The direct observation of watching people, again, is also going to have the whole Hawthorne effect of when someone's being observed, they tend to change what is actually happening. The fluorescence, the one story that I have was when my mother-in-law was in a healthcare setting. We were actually just about to get her out of the hospital. The housekeeper, environmental services person came in with their disinfectant cloth that had been dipped out in the hallway and wiped the edges, the four corners of her overbed table and the control panel on the side rail where the bed is moved up and down, and left the room. That was all she touched, because that's where they must have been doing their marking. It was remarkable for me to observe this. My mother-in-law was discharged shortly after this happened. I did comment to the infection preventionist at that hospital as to what I had observed. But if we're going to do our marking, we don't want to be that consistent or use a product that they can actually see, because then we're going to get into the 100% without touching any other surface. So the study, this was all brought forward. I think Carling was the first paper that really took a good look at auditing what is going on. On this study here, the light bars, the white bars on this graph here are the percentage of high-risk objects that were cleaned, and they sort of bounce around between 20 to 30% of the surfaces were actually being cleaned. So they did a lot of education. They came in with the UV. They gave the feedback, the ultraviolet testing to see if the fluorescence is there. They monitored, they gave the feedback, and you can see the results in the darker bars that the compliance levels then ran from sort of around 70%. What is the magic number with all of this? I can't actually say. Is 70% better than 80%? I just want to make sure that all surfaces have contact with the disinfectant. One of my standard lines is it doesn't really matter what you have in your cloth if it doesn't make it to a surface. So if they're not doing that lovely overlapping wipe of a surface with a little bit of pressure on top of it, we're going to end up with problems around our housekeeping, and it's not the fault of the chemistry in a lot of the cases. So the CDC also talks about how to establish a baseline of using these numbers here, 10 to 15% of rooms, or based on the size of your facility. Sort of do your thoroughness of disinfectant cleaning score, take a look at what's going on, have that number ready to go, use that for sort of the phase 2 of doing ongoing measurement of these high-touch surfaces, making sure that that's reported to everyone that needs to know. This is the kind of information that does need to get up to the C-suite and to the board to let them know that your cleaning and disinfection process is going well. The measurement should be compared to the baseline to show that you've got a good success of things going on. So validation is important. There's systems out there that you can The manufacturer provides you with your fluorescent spray. In this case, ours is invisible. The black light software to allow you to upload this. Most of the software that is provided will allow you to break this down by area, by unit, by staff member, and interventions even in many cases as to what actually went on. I don't really care how you do it, but we need to validate the systems. We need to make sure that what is actually happening in our patient rooms. Unfortunately, this generally gets dumped on someone who generally doesn't have the time to do it. But to me, this is a vitally important aspect of making sure we're reducing the risk to our patients within our healthcare settings, and we're going to drop those healthcare infections as low as possible. My timer just went off, and I'm on a summary slide, so that's pretty good. So 3 things involved here in reducing your risks to our patients. The bottom line is we want the safest healthcare possible for our patients. We're all going to be recipients of care at one point or another, or we've all had family members within healthcare settings. We want to make sure that our products are things that our staff are going to use, that they're fast acting, that they're going to kill the tougher pathogens in as quick as 1 minute would be ideal, but at the same time they're gentle for our staff. You're not going to hear the comments back about the cancer wipes, and they're easy on the surfaces. We need procedures that standardize everything that's going on, that you've got a standardized procedure on how to clean a patient room in this situation, how to clean an isolation room, how to clean an operating room, what's supposed to happen in the lobby or the cafeteria. You need to have very clear steps for everyone to understand what they're supposed to be doing. And then validate that. Make sure that this has all happened and that you've got the right product on the right surface being used in the proper way. I like this diagram because it really does make it look as though this is a juggling process that we've got to go through. We have to balance all of these. At the best of times for all the IPs on the line here, there's a lot of balls in the air anyways. We need to get this standardized, reproducible, and in place as soon as possible, if you don't already have it, to make the safest possible environment for our patients. So, Heather, I think we still have some time for questions.
Yes, definitely. Thank you, Jim, for that informative and enjoyable presentation. As you mentioned, we will now begin the Q&A portion of the program. As a reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Jim will attempt to answer as many questions as he can during the time we have, and here we go. Jim, the first question is, the issue with areas with high turnover who use the product, it is a 10-minute contact time, which is a long time. Many of the products that have a decreased contact time do not kill fungus. What do you recommend?
So in high turnover areas, the risk of fungus and fungal infections is probably not as high as your gram-positive and gram-negative organisms. So a high-touch area or a high-turnover area to me would be like an emergency room. Where having a product with a 10-minute contact time is just not feasible. And most of the stuff that you're going to be worrying about there, if there's not gross visible soiling, most of the stuff that you're worried about then are fecally borne organisms and skin organisms. So you're worried about your MRSA or staph, other species of Staph aureus. You're worried about your E. coli, your Klebsiellas, your Enterobacters, maybe Pseudomonas, the environmental bugs that come in this way. The actual fungal organisms and having to have a label claim for that kind of contact is going to be achieved at the end of day, or if you do that thorough clean of a space where you then get the 5-minute or the 10-minute label claim for the fungus. It's a very hard issue in the high turnover areas, and I remember addressing that as a novice IP. It was one of the first questions, or one of the issues I had to address with the staff in emergency or in places like radiology, where they can process patients through every 5 to 10 minutes, that you have to get something down on that stretcher or that plinth or that supporting structure that's going to be fast and accurate against the more common hospital pathogens.
Got it. Okay. Thank you, Jim. Our next question is, our housekeeping staff have been taught that they are not to clean any part of the patient's bed if the patient is in it. This includes the rails, controller, etc. We're using a quat or bleach to clean patient rooms, and they feel cleaning the occupied bed exposes the patient to a chemical. Is this common practice in a hospital? And if not, how can I provide education to the staff that this is a safe practice for the patient?
Well, you have to go by your HIMSS rating in that situation. And I've been fortunate in my career, and yes, I work for Sealed Air Diversity Care, but I've been using the hydrogen peroxide, the AHP product, since SARS, is when we introduced it to most healthcare facilities in Canada. It's got a huge market share there, I have to admit. But what was handy about that is we could use it around patients. It's a 000 rating. You do not need to have gloves on. I've got reps that I know have actually tried to clean their teeth with this product to see with hydrogen peroxide, will it whiten my teeth? I don't recommend doing that at all. Please don't try your product in your mouth. But I've always been in a situation where I can use the products around my patients because it's safe. We've actually, to using the chemistries that you mentioned, quats and bleaches around patients, it's really what the label claim indicates. We have to be able to clean the immediate high-touch area around our patients because that's where the bugs are going to end up that move from patient to patient, that the patient is then going to come in contact with and then inoculate themselves. We don't purposely walk into a patient's room and put MRSA up their nose. We may inadvertently leave it on their side rail or over bed table where the patient then touches it and puts it up their nose. We don't put C. difficile or VRE up a patient's rectum. Now, some of our endoscopes have had problems, but I'm not going to go down that road at all. But generally speaking, these organisms end up in the patient's immediate environment. The patient then feeds them to themselves. We're not putting them into their mouth. So we have to be able to use a product that is safe around our patients, that is a rapid contact time, and it's going to kill the generally recognized pathogens that we're using. And if it has a superior cleaning capability to it, through the chemistries and the surfactants and all the other products, aspects of the chemistry and product that you're using, that's the bonus on top of it because you're going to remove a lot of the stuff too. So that has to go back to each healthcare facility to address that risk of the chemistry that you're actually using versus the benefits of what it's offering you.
Perfect. Thank you. The next question is, do you find that microfibers are not very effective, or am I misunderstanding?
No, I think microfibers are very effective at picking up materials, bacteria, debris from a surface. They are very good at cleaning. With the appropriate chemistry on them, they're also very good at then killing what might be on the surface also. What I was indicating is you have to check your laundering practice to make sure that these cloths are releasing those organisms, especially if they're still viable, or that they're not picking up more bacteria on the way back to your cleaning area or onto your EVS cart through the process. And it was the paper by Cifuentes, if you actually take a look at it, she states very clearly, we're not sure where these bacteria come from, and that requires further study. All they were saying is the microfiber had more bacteria on it when they sampled them, and these are cloths that were sitting ready to use within the healthcare setting again. I think there's a huge role for microfiber. I think we've got lots of studies that show that it's a superior cleaning thing. It's a matter of making sure that they're not coming back still holding on to those bacteria in a viable state.
Got it. All right, this next question is, why shouldn't you just use bleach everywhere as a daily product?
Why shouldn't you use bleach everywhere as a daily product? It's a lot of the issue around that, again, is why are we using a shotgun when a sniper's rifle would work? To me, if you're using bleach on every surface to reduce your C. difficile problems, you need to make sure, first of all the stuff that I talked about through the procedural stuff, that the product that you're using is getting onto the surface, that the technique that they're using is effective, the cloths are changed appropriately. If then you're still seeing ongoing C. difficile spread, let's look at our antibiotic stewardship program. Let's look at our hand hygiene compliance of not only our staff, but of our patients who may be feeding these spores to themselves that they find in the environment. And then you may need to look at using bleach in a very specific format around patients that are known to be active with C. difficile. I think a lot of times the concept of using top to bottom bleach comes from the papers that are showing us how many of our patients that are asymptomatic without signs of diarrhea are actually colonized with C. difficile spores. We have patients that come into our hospital that have bacteria in and on them. We have staff that come into our hospitals with bacteria in and on them. We've always had procedures in place through standard practices that make sure that we minimize the chance of exposure between patient to staff, staff to patient, and patient to patient. I just personally think that a top to bottom use of a chemical that can damage surfaces, can be irritating to some of the staff, is a little over the top if everything else is in place, I think you will find you don't need to have a product that strong on every surface. I think there's a definite place for using a sporicidal agent, very task specific around, say, a fecal spill in a patient's room who you know has C. difficile. Then fine, okay, I can understand using a sporicidal agent. But from top to bottom, I don't think that's necessary.
Great, that makes sense. Thank you, Jim. This next question says, we are concerned about the microbe removal from patient rooms. My understanding is there is no microbe removal claims on disposable products. This means that even if a pathogen is killed, it would be left there as food to increase regeneration of another microbe that enters the room. Shouldn't we be using a product with a 99.9 removal claim with our proper disinfectant?
Well, I'm not sure if there's a product with a 99.9% removal claim unless you're talking about microfiber, and I don't know what the percentage is of removal claim. I know when our product was first brought to market, the AHP was tested for its cleaning efficacy, and it showed an 86% cleaning efficacy using a standardized test. I don't have it here in front of me. I can provide that reference actually afterwards. And they compared it to quat-based wipes. And it's a standardized test where you use a bunch of oily stuff and I think it was an iron oxide pigment on a white surface. As a positive control, you wipe it with just water to see what's left. As a cleaning control, you use some sort of a detergent, and it should be able to remove 70% of the product that was on the surface. So when AHP was first introduced, it removed 86%. It's a really good cleaning agent. Then, yes, it also has the capacity of killing organisms on top of that. I think we need to get better literature on all of the chemistries there, on their efficacy at cleaning, and then also their efficacy at killing. The actual leaving of debris around for other things to feed upon, we don't have good studies on that. I know we've discussed that internally. I've had the discussion here as to, are there issues with the residue that's left by any cleaning product supporting the growth of other organisms? I'm always worried about anything that has a salty background because Staph aureus loves growing on salt. In the laboratory, we use plates that have 6.5% sodium chloride because Staph aureus will grow on that. Most other organisms won't. So it's sort of a selective agar that we use. So in the back of my mind, I'm always thinking, I wonder if there's residue that's left from some of the chemistries, if it actually does support the growth of the organism. This also will be addressed, though, if we use point-of-care disinfection to make sure that surfaces are wiped frequently. And using a lot of the cleaning cloths that we have will pick up a lot of the stuff.
Okay. Looks like we have time for one more question here, Jim, and that will be, can you elaborate on the Dr. Alpha study, how feedback from the auditing process was delivered positively versus punitively to the end user staff?
I don't think Dr. Alpha went into that kind of detail as to how it was done. It was just basically stated that it was instantaneous or as soon as possible after the room had been cleaned so that the surface could then be re-cleaned. I know when I was doing auditing in my healthcare facility before I came to industry, I had a housekeeper follow me around, and she watched where I found a couple of spots, and she looked at me and she said, you know what? I remember when I came in here, and she had a story as to why she'd missed that surface. So to her, it wasn't punitive at all. She was dying to learn what she had missed and how she could improve because she valued herself as part of our healthcare team. It was very important. I had another room that was under isolation for C. difficile that none of the spots had been picked up. And we wait 24 hours afterwards, and we went back, found the housekeeper, and she said, I tried 4 times to get into that room. Every time they were either changing the patient or the medical team was in there, I could not get into the room to clean it, pointing out to us that we had a procedural issue around the cleaning. And we had to put steps in place to have some sort of a flagging system so that we know that room had not got into. So this doesn't have to be punitive if your environmental services staff feel that they are part of the team. Unfortunately, in many healthcare settings, if not everyone across the board, they're the lowest paid people that we've got. We don't tend to give them the respect that they deserve. I started every presentation that I did to my environmental services staff when I worked back in Kingston, Ontario with, you guys are the difference between life and death, and I appreciate how hard you are working. That's how I started it. And then I went into the issues that we had, and I talked my routine practices up there in Canada and what we need to do with all patient rooms and address their concerns that they had around specific bugs. But I, for one, as an infection preventionist, recognize that a good housekeeper makes me look really, really good because I don't have any outbreaks going on. And I have that quote that I can share where I actually got it from. It actually came from Infection Control Today. But it was a quote that one good housekeeper can prevent more infections than 10 ID docs can cure. So we have to put they're part of the team, and they need to know and let us know what was the issue with why that spot was left.
Great, thank you, Jim. Unfortunately, we are out of time, but I will say that Jim will follow up on the questions he didn't have a chance to address. Also, a reminder to our audience that slides will be sent out in about a week to all registrants. So I want to again thank Jim for the excellent presentation today and for all of our audience members for participating. We look forward to having you join us for future webinars. And this concludes today's program. Have a wonderful afternoon, everyone.
Thanks, Heather.